Hello, everyone, and welcome to the next episode of the CNS Controversies and Neurosurgery Podcast. Today, again, I'm Seth Oliveria. I'm from Portland, Oregon, and I'm joined by my co-host, Rushna Ali, as well as today are very pleased to be joined by our distinguished guest, Dr. Joseph Cheng. He's the chair of the Department of Neurosurgery at University of Cincinnati, and he did his residency and fellowship at the Medical College of Wisconsin. We're going to be discussing lumbar fusions for back pain and low-grade spondylolisthesis. And so I guess before we get started, briefly let you say hello there, Rushna, and then we'll get started with Dr. Cheng.
Fantastic. Rushna Ali joining you guys from Spectrum Health in Grand Rapids, Michigan. Thank you for being with us, Dr. Cheng.
Well, thank you.
And so just to get started here, so, this is the intent of this podcast is to talk a little bit about some controversial subjects in neurosurgery, and one that certainly kind of is a perennial favorite when we kind of talk about controversies is the use of, kind of appropriate use of lumbar fusions. And we appreciate you being here for your expertise. And I thought we'd just start out, kind of going through what you kind of see as just a clear indication for someone who, would qualify for a lumbar fusion, and where you think there's clinical equipoise.
Sure. Well, thanks for that question. Since this is a controversies discussion, I'll just start off by saying when people talk about lumbar fusions for back pain, I think that's a little bit misguided because back pain isn't really a diagnosis. So it's hard to give you a clear indication for a lumbar fusion if you're talking about things like back pain, because really what you need to talk about is what is the appropriate diagnosis. Is a isthmic spondylolisthesis? Is it a non-union of a fracture? Et cetera, then we'll have a better way of approaching it. And I think one of the big controversial discussions is how much training do you really need to have? How much understanding do you really need to have for things related that cause back pain to really be able to identify who benefits from a lumbar fusion? And I think once you do that, then I guess your question about equipoise will also be answered when you go down that path.
Right. And so, you kind of alluded to that a little bit, but what are sort of the, things that are commonly treated, I guess, just for those who are kind of some of our, kind of people early in their training? What's some, common indications for lumbar fusions, and what are some times where, it may be used sort of appropriately or inappropriately, in your opinion?
Yeah, great question. To kind of answer backwards, if you're talking about inappropriate use, it's actually offering a surgery without a clear diagnosis of your goals. So for example, if you have someone with instability, let's say a dynamic isthmic listhesis at L5S1 that has a high slip angle and moves from where displaces 8 millimeters on standing versus supine, with severe back pain related to that, even without neurologic symptoms, you could pretty much agree that that's something that needs to be treated. Or similar to any joint arthropathy with load bearing, if you have severe facet arthropathy or disc arthropathy, where you can diagnose, for example, uptake on scans like bone scans, or clear indications of load bearing like upright posture with intractable symptoms. Those are reasons to offer fusion, such as to increase the biomechanical stability. I think the challenge is when you don't have a clear indication, it's non-specific back pain, you can't localize it, and then the surgery becomes hit or miss, whether or not you, kind of like hitting the lottery, getting the right spot for the patient, or really missing the mark on the diagnosis and doing a surgery that may not have any efficacy whatsoever.
Right. And I think you kind of get, your answers to the question kind of also kind of gotten to the underlying kind of issue that, low back pain is so common. Mm-hmm. And, it's not all surgical. And I think anyone in kind of practice, gets, kind of constant referrals for people with low back pain. And it's sort of our job to differentiate between those people we can help and those we can't. And I guess you mentioned in kind of briefly that there are certainly patients who have neurologic symptoms, radiculopathy, or certainly kind of more severe neurologic symptoms, that kind of are kind of indications for operating might be a little bit more clear. But again, getting back to what you kind of had said, that low back pain is so common, and that's really kind of what we're talking about today. And I think we could all agree a patient who has severe radiculopathy, or with kind of foraminal stenosis and things like that, it's a little bit more clear sometimes. But in your practice, when someone comes in with back pain, and kind of with or without sort of imaging findings or other kind of test findings that may support that that they're a surgical candidate, what how do you counsel those patients, kind of both with and without kind of clear evidence of their something that you might be able to help them with?
Sure. I think it really starts off with, as I mentioned before, diagnosis. I would probably challenge most of our neurosurgical colleagues, the next time they look at the MRI scan, especially the axial T2s, just look at the paraspinal muscles, and just to see, have you ever diagnosed anybody with chronic lumbar strain or even chronic lumbar sprain, related to the muscles and ligaments as a source of back pain? Because I think once you get down to the diagnosis, it then gets into really addressing what the patient's pathology is. Similar to, any other subjective symptom, like, what, for example, like trigeminal neuralgia, if you can't localize the pain into a specific V2, V3 distribution, and it becomes atypical facial pain, the odds of the patient improving becomes really distinctly different for microvascular decompression, for example, than someone with a classic trigeminal neuralgia. And I think that's the same issue we have with, low back pain. That with low back pain that's, clearly identified with, with a pathology that can respond to surgery like a lumbar fusion, you still will have patients, whether it's, psychosocial issues, work comp, somatization, that just will not get better because there's just no way for you to prove or disprove. However, I think what you really need to look at is, you're not going to cure everybody, but is your success rate high enough? And I think that's why collecting the outcomes data, looking at our long-term, patient results becomes so key.
Yeah, I think that's really an excellent point, that you kind of compared to other things that we treat surgically, that if you don't have a proper diagnosis, I think that trigeminal neuralgia kind of analogy is really kind of apropos, that if you don't know what you're not going to do a brain surgery on someone if you don't know where their brain tumor is. It's kind of the same sort of.
Well, it's the same thing with back pain. I can tell you, I see a lot of patients. I mean, I've even diagnosed patients with prostatitis in my clinic, just because depending on where you practice, you have a middle-aged person who has known, age-related spondylitic changes. They have acute back pain. A lot of times with PCP, the first thing they do is refer them to the surgeon to evaluate. I think that's the distinction. Someone with trigeminal neuralgia or epilepsy will typically see somebody else first before they hit the surgeon. But for things like spinal disorders, it's not unusual for the primary physician to refer directly to a surgeon to evaluate and manage, including expecting us to manage or to order the non-operative modalities, which is why I think it's so key for us to have a good understanding of the diagnosis and to really give the patients the options, based on what you diagnose.
Yeah.
Building up on that, Dr. Cheng, what components of multidisciplinary do you currently have in your practice, or think a good, robust spine practice should have to be able to take that onus off of the surgeon somewhat and be a part of shared decision making and be able to treat all types of pain syndromes, whether or not they be surgical or not?
Well, good thing this is a controversies thing, so I'll say something kind of controversial on this, is that sometimes I don't think those, aside from surgeons, will really put in the effort to do that. The reason I'm not criticizing, many of our colleagues, but for example, many of the pain physicians we talk to, will start managing pain without a diagnosis. Like they're not ordering MRIs to try to figure out what's going on with the patient. They're not really digging deep into it. They're just trying to manage the patient's symptoms. And same thing with our physiatrist colleagues, where many of them don't specialize in spine physiatry. Some do, don't get me wrong, but many of them are doing spine as much as they're doing sports medicine, looking at knee pain and other things. And so really what it comes down to, and I think this is something that we just have to accept as a neurosurgeon, is that we do a lot of spine, whether it's in private practice or, a general practice or a spine specific practice. Overall, spine pathologies are a large percentage of what we do. And like I said, frequently it bypasses. The challenge I think we have is when we try to do the knee jerk reflex and create teams kind of handing off the diagnosis to, advanced practice providers or others that actually may not have the same understanding of the spinal anatomy and pathology that we do, given our training, and so I think it's just one of the things I would probably say is, again, not to be overly controversial, is we have to watch out that surgeons don't assume that being a good technician for spinal, a spinal procedure from a weekend course turns them into a good spine surgeon.
Right. And, and in that kind of line of thinking, do you have any recommendations or kind of, clinical pearls or things that you would, when you have a patient sitting in front of you that comes in with some spondylitic changes and primarily complaining of back pain, when you're seeing that patient, what what questions would you recommend that people really focus on to differentiate between people with surgical and non-surgical?
Mm-hmm. Great question. It's ironic that the model that I use is very similar to how I actually suggest people to study for taking the oral boards. So if you have a patient in front of you, what's the first thing you do? You collect a history and physical, right? Chief complaint, the collection of the symptoms, collection of signs. And then what do you do with the history and physical? You localize the lesion, right? You try to figure out what part of the anatomy has the highest likelihood of having those symptoms. So for example, if it's neck and arm pain, is it Parsons Turner with a brachial plexitis, or is it a cervical radiculopathy, or is it a rotator cuff injury? And you can actually, and that's why when we talk about things like the boards, differentiating perineal nerve palsy from an L5 radiculopathy, for a drop foot, I think that's the key. So I think that's the first thing I would say is localize the lesion. So if you think it's facet arthropathy, doing provocative testings, for example, similar to a Sperling's, where you do a extension oblique view or a maneuver to see if you can load the joint. If you're not exactly sure, that's when you do, your confirmatory testing. So for example, medial branch blocks, facet injections, if you're localizing it to that. Disc blocks, if you think it's, disc-related symptoms related to that. Just as some examples, if you think it's, overloading joints with arthropathy or the vertebral bodies, then get a whole body bone scan or a CT SPECT to see if you have uptake, from bone stress. Those are just some of the things I would suggest as far as how we localize and diagnose.
And in terms of those types of testing that you just referred to, how often are you using those in your practice?
Ooh, quite a bit.
Yeah.
So, and it kind of gets into, based on the diagnosis that I think we're leaning towards, I will then triage the patients to the other options. So for example, if you're asking for epidural steroid injections, you have to think about what's your goal. Because ironically, epidural steroids are still not FDA approved, right? So this is the funny thing is that we are so focused on worrying about offering surgery to patients, but the FDA still has not approved steroids in the spine with their black box statement talking about the risks of complications being higher than any sustainable benefits from that. But it's something that is standard of care. People order it all the time. And so I think this is what you need to think about is what is your goal with that injection? And I think the same thing with physical therapy. If you look at the various modalities that therapists can do, which, if you ever wanted to figure out what they can do, just see what people get paid for. And so if you look at CPT codes and what people get paid for, you can pretty much get an idea of what kind of procedures people do. And the therapist, sometimes when you look at what they can do, you also want to think about what is the goal for the patient? Are you treating a chronic lumbar strain? Are you treating, a facet arthropathy, that, is causing, severe axial pain from loading, etc. And then that may help you kind of guide how you assess the patient in clinic and then what options you give them.
That's really great. And like I said, this is something that any neurosurgery resident or, kind of practicing neurosurgeon runs into this, frequently, I think, regardless
Absolutely.
of your subspecialty. And then, in terms of, kind of someone where and I guess you kind of already addressed this, but someone who comes in with kind of back pain or maybe kind of a, multi-level kind of mild spondylolisthesis, how are you deciding between different levels of the spine? Are you using, blocks and things like that? Or, if someone has kind of multi-level changes and, you're trying to decide if they need a big surgery or a small surgery, any kind of words of advice about that?
Mm-hmm. Yeah, absolutely. I think localizing the levels is pretty key. And I think that's one of the challenges you see. I mean, we've been criticized as a specialty sometimes, for being so focused on spinal deformity these days, that someone with an L4-5 stenosis and a shopping cart posture is diagnosed as a positive sagittal balance and offered a, major kyphotic revision or kyphotic surgery with osteotomies, etc. And I think that's where the diagnosis becomes key overall. As far as, some of the, the aspects of the levels, I do think it's important to really be able to identify, which levels and what you're trying to really address. And so things like diagnostic injections, for example, for example, if you look at the lumbar fusion guidelines from the spine section, if you look at the literature, disca blocks, if you're thinking it's a discogenic symptom, the extinction of the symptoms, actually is a more reliable approach, at least based on the literature we have, than say discograms with provocative testing. That being said, there may be other reasons you choose different levels, including things like, lumbar kyphosis, things like that. But I do think that's an important thing. And how I personally do it is a combination of diagnostic injections, looking at the morphology. So, for example, if the CT scan shows, severe arthropathy that, or is hot on bone scan at multiple levels in the spine, that would drive me to do a multi-level approach than a single level, especially if I can't isolate it based on a neurologic presentation like radiculopathy.
Yeah. And you kind of alluded to my next question, which is, for the patient who has some neurogenic claudication and back pain, I think that sort of sometimes can be a difficult person to decide when they're, in front of you in clinic, whether they can get away with the decompression alone or whether that person needs a fusion as well. And, obviously that depends a lot on the details of their imaging and whatnot, but, for those patients that have some back pain that may be kind of a form of claudication, and they respond, partially to injections and things like that, and maybe have a slight spondylolisthesis or something like that. Those patients where you're definitely kind of on the fence. Do you lean towards fusing that person, or do you think about doing a decompression and see how they do in that situation?
Mm-hmm. It really depends on the patient's situation. So, for example, you kind of alluded to dural irritation causes back pain. You see that with subarachnoid hemorrhages. That's one of the symptoms. Meningitis. That's why we have Koenig's and Brzezinski signs. And even Mixter and even Hall with Mixter and Barr's original work, people with disc herniations will have some component of back pain from dural irritation from their disc. So we see that overall. So I think it's important to kind of look at back pain, not necessarily as a knee jerk that you need, stabilization and hardware, but as much as, is it associated with instability or something that you really need to potentially reconstruct? So, for example, even with a degenerative listhesis, if I'm decompressing for radiculopathy and doing it through a MIS or tubular approach, I don't just jump ahead and do fusions for that. On the other hand, if I'm doing it as a second or third time revision after maybe prior MIS procedures, then yes, and I start saying I'm going to potentially be resecting enough of the surrounding joints that I'm going to end up with instability, with the back pain being really similar but across both sides, for example. So I think that's how I personally approach it. And I think the decompression, we do decompressions all the time, but it is interesting that over time, for example, I still do posterior cervical laminectomies as needed for patients, same with lamoplasties. And I think the idea of preserving the capsular ligaments. So, as neurosurgeons, we know that if we violate the capsular ligaments, like bilateral perch facets, no bony injuries, you violate that, you're going to get instability. How's that different than when you cauterize the capsular ligaments on exposure, creating iatrogenic instability? Same thing in the lumbar spine. If you're cognizant of the ligamentous integrity of that region, and you can do a decompression without violating it, I certainly think fusion is not needed at that time. On the other hand, if you do violate it, or iatrogenic instability, like someone with a foraminal stenosis, that you're trying to get, the lateral recess and you get a little bit too far and you fracture the pars, certainly stabilize it, and I think those are just some of the things that, or some of the variables that we have to take into consideration.
And then for a patient where really the goal of the surgery is to treat axial back pain, are you, I guess we haven't kind of defined what we mean by a fusion, and that sort of is different patient to patient, obviously. But for a patient where you're really not looking for neural decompression, are you thinking about anterior or lateral approaches or percutaneous screws? Or obviously it's patient to patient, but patient where you're not looking for neural decompression, are you doing sort of anterior and lateral approaches for those patients?
The short answer is yes. I mean, if we didn't have the ability to diagnose, pathologies with isolated axial pain that doesn't need a decompression, then things like disc arthroplasty wouldn't even be needed. Because if you think about it, how many of us, aggressively decompress the spinal canal with an anterior lumbar approach? Everything's done indirectly. Same thing with lateral approaches. Now, that being said, I do think there are times, if you look at some of the literature that's available, that, for example, adjacent segment spondylosis, where you have patients with adjacent segment disease, say at L3-4 above a prior posterior lumbar fusion, that things like the anterior standalones, in one way or another, certainly have a benefit. So those are just some examples that I think we can all pretty much agree with, that if we're able to diagnose that the patient results are also fairly consistently good for giving them those types of options.
Well, that's great. I've asked a lot of questions. Rushna, did you have any questions for Dr. Cheng?
Of course. So since this is a Controversies podcast, Dr. Cheng, what are your thoughts on using neuromodulation in low back pain and completely virgin backs who might also be candidates for a fusion procedure? And considering we're not talking about patients who have severe stenosis, who have claudication, etc., but mild spondylolisthesis, some low back discomfort. Are there situations where you would consider neuromodulation prior to an open fusion on these patients?
Yes, I think they all have their roles. I would say that neuromodulation, spinal cord stimulators, similar to morphine pumps, others, are certainly a good way of addressing the pain symptoms themselves. But I think one of the big keys that I think is misunderstood is really the natural history. The lumbar fusion alone is not really meant to address pain per se. It's meant to address a pathology that potentially has a progressive course. So, for example, if someone has a fracture dislocation and they're going to have a progressive listhesis, I don't think anybody's going to argue that stabilizing that is bad. Can you still treat that symptom or symptomatically with neuromodulation? I suspect you probably could, or a morphine pump at that level. However, that being said, I think that they have different reasons. So if you have a patient that has a fairly static pathology, for example, in 80-year-old who has a stable spondylosis and arthropathy with pain that's fairly diffuse that you're not really going to be able to reverse, I think using neuromodulation certainly would be a good option for that as well. On the other hand, I think if you have something that you're worried about the natural history of progression, say, a vertebral body metastatic lesion, sure, you can mask the symptoms like we used to do for cordotomies, for chronic pain, but you're probably going to want to treat the tumor, right? So I think that's where we really have to look at drawing a line. And I think that's the important thing for neurosurgeons, is that we're not a one-size-fits-all type of group. And that's why we have so many subspecialties with expertise. But overall, even though we all are all subspecialized, it's important for all of us to be cognizant of what pathology we're treating.
I think that really gets back to your point. There was recently actually one of the other CNS podcasts was on neuromodulation, and there was an argument made that you shouldn't be doing very much redo spine surgery, that if someone fails, just go straight to neuromodulation. And I think that gets back to your guiding principle of knowing the diagnosis. And, obviously if you sort of do a surgery and it doesn't help and the person's still symptomatic, but if they have progression of their underlying condition and need a bigger surgery, years down the road, then that's a different situation, obviously.
Well, unfortunately, I saw a patient today in clinic that has not only revision surgeries, but a spinal cord stimulator, that the natural history is that the hardware kept loosening, now sustained pedicle fractures, subsidence of the cages that are now displacing anteriorly. So that's why I was saying that we can mask the symptoms for a period of time, but if we don't treat the underlying issue, like the guy's vitamin D was 16.4, right? So it's one of these things where between bone biology issues, loosening of the hardware, we still got to treat the underlying pathology based on our diagnosis.
I think that's very good advice. Well, I think we're getting towards the end of our time. Dr. Cheng, can you think of anything that we didn't talk about that you would like to convey to our listeners?
No, I think these are certainly poignant questions, and I really appreciate the opportunity for me to sit here and just kind of share some of my views on this.
Yeah, well, like I said, it's very common and important to kind of think through these issues. And I guess we'll kind of wrap up there. And again, thank you for your time. Thank you, Rushna, for joining us. And for all the listeners, go to cns.org and check out the rest of the offerings in terms of our education material. And we'll call it the end of the episode there. Thank you guys very much.
All right. Thank you.
Thank you, Dr. Cheng. Thanks, everyone.